healthcare associated infection or hospital acquired infections. The terms are synonymous. There are few terms like iatrogenic infections. Anybody any idea about iatrogenic infection? Iatrogenic infection, do you have any idea about iatrogenic infection? What is iatrogenic? What is healthcare associated or hospital acquired infections? Healthcare associated infection and hospital acquired infection are nearly similar term. The difference is that previously hospital acquired infection was a term, patient was admitted. The admitted patient, hospital acquired infection term was used, but even the patient attending OPD may acquire the infection. OPD, other healthcare status, so healthcare associated infection would be a more proper term. Healthcare associated infection. Now, what you should know? You should know what are the major types of HAI, how you can prevent the hospital acquired infection, and hospital infection control committee. What are the function and constituent of hospital infection control committee? So before we start the major HAI definition: infections acquired in the hospital, admitted for a reason other than the infection. That means patient was not having that infection or not in the incubation period for that hospital acquired infection. So that's why there is a time factor, 48 hours after admission. It may be 2 calendar days. So definition of any HAI you have to mention after 48 hours of admission or after 2 symptoms should appear after 2 calendar days of admission. Symptoms may appear even after discharge. Occupational infection among the staff, needle stick injury, these are also part of hospital acquired infection. According to WHO, 7% of the patients in developed country and 10% in developing countries acquire at least one of the hospital acquired infection. Mortality is 10%. So what are the factors? Immune status of the patient, the hospital environment, hospital organisms, diagnostic or therapeutic interventions, transfusion, poor hospital administration. So these are the factors affecting or increasing the rate of hospital acquired infection. Now, this point, hospital organism. If you get the same organism more often in a hospital acquired infection, that means that organism is harboring in the hospital. Which is the commonest site or commonest word where hospital acquired infection occurs? Any idea? Which is the commonest area of the hospital where the hospital acquired infection mostly occurs? It is in the ICU. Not in all wards. ICU, because most of these hospital acquired infections are device associated. Some device is there in the patient, some intervention were done. That's why the hospital acquired infection has occurred. So ICU is the commonest site for hospital acquired infection other than surgical site. And hospital organism in the West Bengal setup, the most common organisms are gram-negative bacilli and MRSA. That is methicillin-resistant Staphylococcus aureus. These are the most common. We get Klebsiella, Acinetobacter. These are the common organisms we get from the hospital acquired infection samples. So the source of infection may be patient's own flora, because if you think of catheter-related bloodstream infection, coagulase negative staph is the common. So coagulase negative staph is the flora of the patient himself or herself. Exogenous inanimate object like air, water, food, healthcare worker, hands of the healthcare workers harboring MRSA. So many healthcare workers, there are many studies that many healthcare workers have a nasal carrier of methicillin-resistant Staphylococcus aureus. If they touch the nose and then touch the patient without hand washing or without gloves, that may lead to a hospital-acquired infection. So this is one point you should remember: the hands of the healthcare worker or the nose carrying the MRSA. And if the hand hygiene or gloves is not used, the infection can spread from one patient to the another. Escape organism. These are the major organisms for hospital-acquired infections. Escape means E for Enterococcus faecium, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas aeruginosa, and Enterobacter species. Though the name of the Enterobacter now has been changed to Klebsiella itself. So these are the escape organism. Question may come from escape organism also. Other organism, Escherichia coli, COVID-19 recently, nosocomially acquired Mycobacterium tuberculosis, Legionella pneumophila. Can anybody tell what is the infective period for Mycobacterium tuberculosis infected patient after starting of anti-tubercular drug? How long the patient remain infectious? If the patient is kept in a ward where other patients are there, how long, what is the duration after which the patient becomes non-infectious? What is written, it is 14 days, 2 weeks. Even after starting the treatment, the TB patients remain infectious for 2 weeks. So patients should use mask, and also the healthcare worker, that patient should be kept in a separate isolated room, and healthcare worker should also use mask. So TB patient, even after starting the treatment, remain infectious for 14 days. Legionella pneumophila. Any idea where Legionella pneumophila is there? From which equipment it usually passes to the patient? It is through the air conditioner. Legionella pneumophila may be AC borne. Blood-borne, blood transfusion with HIV, hepatitis B, hepatitis C. They are part of hospital-acquired infection. So should prevent this type of contact, droplet and airborne transmission. I will not go into details, just can you tell what is the difference between droplet and airborne? Aerosol and droplet. What is the main difference? Aerosol, the main difference in the size. Droplet is more than 5 micron and aerosol or airborne is less than 5 micron. COVID was taken as a droplet infection. That means size was more than 5 micron. Airborne, aerosol should be less than. Now these are the major 4 types of common hospital-acquired infection you should know. Long question has come the previous years. There is a long question on ventilator-associated pneumonia. So you should at least know about these central-associated CAUTI, CLBSI or CRBSI, VAP and surgical site infection. Now prevention of HI will come later. Standard precautions. So what is the most common preventive measures? Following standard precaution and following transmission based specific precautions. Standard precaution should be followed by all individual, all specimen, all needles and all sharp. Universal precaution was the previous term. Now the term has been changed to standard precautions. So these are component of standard precaution. Hand hygiene, personal protective equipment as required, biomedical waste management, spillage cleaning, disinfection of the patient care, environmental cleaning, respiratory hygiene, cough etiquette, safe use and disposal of shard. Now, environmental cleaning, previously, OT was cleaned by fumigation. The fumigation is not advocated nowadays. For any environmental cleaning, the surface should be clean. That means the floor of the ICU should be cleaned at least 2 hourly. Floor cleaning, because most of the droplet infections goes down to the floor. So surface cleaning is the most important part of the environmental cleaning. Hands of the healthcare worker, one of the main source of infection. Hand hygiene is most important to prevent healthcare associated infection. What it is told that hand wash can prevent 85% of healthcare associated infections by simple hand washing or using hand rub. So types of hand hygiene, either you can use hand rub or you can use the soap and water. Hand rub duration is 20 to 40 seconds, and if you wash with soap and water, the duration is 40 to 60 seconds. So duration is different, 20 to 40 or 40 to 60, where hand wash with soap is mandatory. Hand wash with soap is mandatory in which two conditions? Can anybody tell where hand rub will not be effective? These are the two parts of hand washing. One is hand rub, one is washing with soap and water. So two conditions, at least there are two conditions where hand rub is not at all effective. One is when you need to know that the area is visibly soiled. When the visibly soiled area you are touching, gloves is mandatory, and also after if you wear gloves and gloves has been soiled, then after that you have to wash your hands with soap and water for 40-60 seconds. Hand rub will not be effective. So one part is visibly soiled. Second point, if any patient harbors Clostridium difficile, that is pseudomembranous colitis, another hospital-acquired infection, where the washing with soap and water is mandatory because Clostridium difficile spread cannot be prevented by hand rub use. So this is all have been taught in practical. What are the moments of hand hygiene and what are the one point just I will cover, where you should use gloves as a part of standard precaution before a sterile procedure, anticipation contact with blood or body fluid, as a part of contact precaution, contact with the patient, heavy duty gloves for sharp injury and for spillage cleaning or biomedical waste handlers. As soon as gloves are damaged, should be changed. Gloves are meant for single use only. So in between the patients, the glove should be changed. Gloves are not recommended. Routine patient care, measuring blood pressure, administering IV medication or oral medications, during maintenance of IV cannula, during writing the patient case sheet. Now this point can come as a explain why. Gloves is not a substitute for hand washing. Why the gloves is not a substitute? Because hand hygiene should be done before the gloves use, hand wash after the glove use. Gloves should be worn for a single patient care. Gloves must be changed between the patient contact. No hand hygiene over the gloved hand. Gloved hander opor kintu we should not follow the hand hygiene. This dictum was broken during COVID. Hand hygiene was also practiced in gloved hand. But otherwise, you should not, or hand hygiene should not be practiced over a gloved hand. Now let's go to the types of HAI. This is a summary of the precautions. Standard precaution. For standard precaution, isolation room is not required. but hand hygiene is required, gloves may be required, apron or gown if soiling is likely, mask as required, eye protection as required, handling of equipment, single use or reprocess, no additional precaution. So this is a part of standard precaution. For contact precaution, isolation room is essential, hand hygiene is essential, gloves essential, apron or gown is essential, and handling of equipment same as the standard precaution. Droplet precaution, isolation room is essential, hand hygiene is essential, gloves as required, surgical mask is essential, and for airborne, N95. So if you go to tuberculosis, whether it is a airborne or droplet infection, Mycobacterium tuberculosis is an airborne infection. So airborne infection, so when you are going to an untreated or patient within the 14 days, a TB patient in an isolation room, you should use N95 mask. Now Hospital Infection Control Committee. Short note may come from Hospital Infection Control Committee. Let's just know what are the multidisciplinary input. HICC is advisory to the medical superintendent and makes its recommendation. What are the committee member for Hospital Infection Control Committee? Either the chairman is medical superintendent, member secretary is HOD microbiology, Hospital Infection Control Officer, representative from the Department of Microbiology, Hospital Infection Control Nurse, head of the all clinical departments, all medical and all surgical, nursing superintendent, head of the staff clinic. So these are the statutory members of Hospital Infection Control Committee. Operator room supervisor, in charge CSSD, in charge pharmacy, in charge hospital linen, in charge of the hospital kitchen and epidemiologist. What are the functions? HAI surveillance, policy, review and update the hospital infection control policy from time to time, education of the staff or other healthcare worker, staff health, pre-employment checkup or during employment yearly checkup or outbreak management. These are the part or functions of Hospital Infection Control Committee. Other department communicates and cooperates with other department. HICC shall meet regularly, not less than once a month. So, Hospital Infection Control Committee meeting should be conducted every month. Now, major HAI. Already I have discussed, these are the four main HAI, catheter-associated UTI, catheter-related bloodstream, VAP, surgical site infection. Now, go one by one. Now, what are the device associated? What are intervention? Device associated, most common three. One is CAUTI, that is catheter associated UTI, catheter related bloodstream infection, and VAP. These are three device associated. Surgical site is following any surgery. So these are four major types. Other 8 categories, device associated and procedure associated. Already I have mentioned. Others, skin and soft tissue infection. A patient admitted with burn, he may have an infection with organism when admitted. What are the 2 common organisms which infect burn patient? Can anybody? Burn patient? If the patient is admitted in a ward, what are the 2 most common organisms that affects burn patient? One is Pseudomonas aeruginosa and another is methicillin-resistant staph aureus is the second common. The most common is Pseudomonas aeruginosa and the second common is gastroenteritis. Gastroenteritis either may be antibiotic associated or nosocomial infection. Rotavirus in case of children and Clostridium difficile is a major cause of antibiotic associated diarrhea. Clostridium difficile is now detected more often by use of either PCR detecting the toxins or ELISA detecting. Clostridium difficile, you know, they have A and B toxin. So these toxin can be detected either by ELISA or by PCR. So Clostridium difficile is more often detected nowadays. Sinusitis, these are other infection, endometritis following any surgery or following childbirth. Now start with CAUTI. CAUTI is the most common hospital acquired infection. Catheter-associated urinary tract infection are most common. 40% of the nosocomial infection are CAUTI, presence of indwelling catheter. Now, what would be the definition? Definition of CAUTI. First, you should write the definition. That means the symptoms of urinary infection appearing in patient after at least 48 hours or 2 calendar days of infection. And patient should have a significant bacteriuria. Defined as a significant bacteriuria in a catheterized patient. Catheter-associated UTI is a term. Catheter-associated asymptomatic bacteriuria is not used mostly. So you should, I have not written that 48 hours part. When you write definition in any healthcare associated infection, mention the 48 hours duration. After admission, 48 hours duration or 2 calendar days should be there for definition. CAUTI rate varies from 0 to 5 per 1000 catheterized depending upon the hospital infection. How the rate is calculated in CAUTI? It is calculated by number of CAUTI cases, number of catheter days. Catheter days mean how many patients having catheter for how many days, and into 1000. So this is how the rate of CAUTI is calculated. Rate. So it is by 1000 catheter days. It is usually per 1000 catheter days how it is calculated. That is the calculation of CAUTI. Most common is gram-negative bacilli, Escherichia coli or Enterococcus, maybe the common organism, Klebsiella, Pseudomonas, Acinetobacter may also occur. Enterococcus is the most common gram-positive cocci for the CAUTI. Maybe polymicrobial or pathogens of short-term catheterization plus Proteus, Providentia, Morganella can also occur. So how the infection occurs in CAUTI? There are 4 sources or 4 points. When urethral meatus, catheter junction, second part where the junction between the discharge tube and the bag, and third part, this is the connecting part of the drainage bag, and that is the outlet valve of the drainage valve. These are the 4 points where the chance of infection can occur. First is urethral meatus catheter junction. This is the urethral meatus catheter junction. Second is balloon inflating port. Third is where the catheter connects with the drainage bag, urobag. And fourth is outlet valve of the urobag. Either may be extraluminal, patient's endogenous flora, or hands of healthcare worker, interluminal spread, open drainage bag or breach in the closed drainage system. Directly proportional to the duration. So as the duration of catheterization increases, there is a chance of CAUTI. So these are common risk factor, long term more than 30 days, type of catheter material, latex catheter has a high chance of CAUTI, then silicone catheter. If you know the catheter should be kept for long time, try to use silicone catheter. Silicone catheter is also available. Commonly what we use is the Foley's catheter, which is a latex. So Foley's catheter has a higher chance of CAUTI. Female patients have a higher chance of developing fatal underlying illness, older age, diabetes, poor personal hygiene, fecal incontinence, caregiver, failure in adherence to aseptic technique, and emergency catheter insertion outside the operating room. What are the other factors? Urethral pressure. An indwelling catheter exerts a lateral urethral pressure causing a decreased mucosal blood flow. And in catheterized patient, bladder is often incompletely void, incompletely emptied. A pressure difference created by the patient movement, a small amount of urine always around the balloon, which serves as a nidus for infection. So these are the 2 points. Also, promote the development of CAUTI. Now lab diagnosis. What should be the sample? Sample is catheterized urine. From where you will take the urine? From the catheter port, never from the urobag. So ask the healthcare worker who is collecting urine or sending the urine to microbiology department, always collect the urine from the port of the catheter after cleaning the port. After cleaning the port, the catheter should be collected, urine should be collected with a needle and syringe. Never from the urobag. You mention in your paper or mention in your viva, the urine should never be collected from the urobag, but it can only be collected with a syringe and needle through the catheter port. Now clinical criteria. Criteria for diagnosing of CAUTI. Presence of at least one signs or symptoms of UTI. Fever, suprapubic tenderness, costovertebral angle pain, urinary urgency, frequency or dysuria. And presence of significant bacteriuria. What is significant bacteriuria normally? What is significant bacteriuria? You all had in your practical class. Significant bacteriuria is 10 to the power 5 CFU per ml. 10 to the power 5 CFU. In asymptomatic patient, it is 10 to the power 5 CFU, but in symptomatic patient, it is 10 to the power 3. What is the treatment? Removal of catheter, appropriate antimicrobial therapy. Treatment of asymptomatic bacteriuria is not indicated. If asymptomatic bacteriuria persists for more than 48 hours, removal of the catheter. Now, what are the bundle interventions? This is usually asked. What are the bundle care for prevention of CAUTI? Bundle care means these are bundle care. Place bladder catheter when absolutely necessary. Use aseptic technique for catheter insertion. Minimize manipulation or opening the drainage system. If bladder catheter is needed, ask daily. How will you ask the bladder catheter is essential or not, whether the catheter can be removed or not? If you go to ward when the patient is on catheter, the urine is passing through the catheter. How the patient can tell catheter is needed or not? So you have to clamp the catheter and patient will say he has some he can void the urine. After you clamp the catheter, if the patient can tell he requires urination, that means catheter can be removed. So catheter should be clamped and patient should be asked whether he can feel the pressure in the bladder. So this is bundle prevention. Catheter related bloodstream infection. In which patient it will occur? Again in ICU patient, the patient having central catheter, central line. Either it is central venous catheter. So presence of central line as a source of infection, not associated with any other secondary cause. Patient admitted with endocarditis. That means there is a cause for bloodstream infection already. So that time differential diagnosis should be done, whether due to the catheter related or the patient already had some bloodstream infection. Intravascular device that terminates in the great vessel, need for various purposes, central venous pressure monitoring, administration of drug, total parenteral nutrition. These are the indications for central line therapy. So systemic antibiotic therapy, empirical therapy, according to the organism of your institution, and antibiotic lock therapy. It is a special therapy for CRBSI. Salvage of the catheter is considered, where catheter cannot be removed. Patient to be continued with catheter. Then we use these things, antibiotic lock therapy. In installation of highly concentrated antibiotic solution in the central line lumen and is left there for short period. So this is antibiotic lock therapy where the catheter cannot be removed immediately. Patient in such a condition where the central line cannot be removed immediately, we can use an antibiotic lock therapy. Now the treatment already covered systemic antimicrobial therapy. So what is the common organism? What we have discussed is cons. So gram-positive coverage must be there. And these cons are mostly methicillin resistant. So drugs which are effective in methicillin resistant cases should be given for cons and also gram-negative coverage to be given. What is the antibiotic used in methicillin resistant staph or methicillin resistant cons? Vancomycin for IV and linezolid is also effective in MRSA. This is bundle approach for preventing CRBSI. Avoiding catheterization unless it is medical indication, maintaining a high level of asepsis for catheter insertion, limiting the use of catheter as short duration, preparing fluids aseptically, and training of the personnel in catheter insertion and care. So this is the bundle approach for preventing CRBSI. Now VAP is the second most common after CAUTI. 15 to 20% of HAI are ventilator-associated pneumonia. Most common cause of death, mortality rate is up to 40%. Primary cause of death in ICU, VAP rate 1 to 46 per 1000 mechanical ventilation days. The calculation is same like CAUTI. Here we used CAUTI. Here we use VAP and number of catheter days or number of mechanical ventilator days. So the same 1000 mechanical ventilator days is the calculation. 1000 mechanical ventilator days is calculated for the VAP. What is the new term for VAP? Pneumonia is the last stage. Initially, now it is being termed as ventilator associated events, VAE, ventilator associated event, because initially pneumonia does not occur, but if you detect the ventilator associated events, we can go for the prevention, further prevention. So early onset VAP, difference, what are the organisms implicated for early and late onset? Early means in the first 3 to 4 days and late means after 4 days of mechanical ventilation. So typically caused by the gram-positive, MSSA, pneumococcus are the early onset, and late onsets are commonly due to the gram-negative organism like Acinetobacter, Klebsiella, Pseudomonas and MRSA. In West Bengal, Acinetobacter and Klebsiella are the two most common organisms in West Bengal setup, and also in some part of the India. These two are the most common organisms isolated from the VAP patient. Pathogenesis, first is colonization with hospital multi-drug resistant organism. Endotracheal intubation disrupt the normal defense. Biofilm, the reservoir of infection. Biofilm occur on the endotracheal tube. Subglottic secretion, microaspiration. As the patient is usually unconscious, there is continuous microaspiration during ventilator use, prevented by maintaining cup pressure between 20 to 30. So these are the points where the VAP can occur. Pathogenesis, sedation, lead to increased chance of ventilator-associated events. Supine position, it facilitates microaspiration. Nasogastric tube, critical illness with comorbidity, and stress ulcer prophylaxis. So, duration of ventilation, nasogastric tube, that is Riles tube, frequent change of ventilator circuit, fail subglottic aspiration, use of antibiotics or sedatives, stress ulcer prophylaxis, tracheostomy. Advanced age, prior hospitalization history, supine position, critically ill with comorbidities like already patient having other respiratory comorbidity like COPD or ARDS, or patient neurological patient with head trauma, patient with coma, and burn patient, improper adherence to aseptic technique. So these are the three parts. You write the risk factor divided into three parts. No gold standard criteria available that define VAP accurately. That means 6 parameters. VAP is also how it is defined. The symptoms of respiratory distress or CPIS score. I am timing to CPIS score. Deterioration of the CPIS score after 48 hours or after 2 calendar days of the patient having under mechanical ventilation. The CPIS system is based on 6 parameters: clinical, radiological and microbiological. Maximum score is 12. Score more than 6 is diagnostic. So you need not remember all the points in detail, just remember what are the check. Temperature, if it is more than 36.5 or less than 38 is 0, but if it is more than 39 and less than 36, 2 points. So leukocyte count, if it is raised either below 4,000 or above 11,000, tracheal secretion, is it purulent, oxygenation, PaO2 FiO2 ratio, chest radiograph and tracheal aspirate culture. This is the microbiological part that should be highlighted in your answer. How will you diagnose the VAP? Microbiological criteria or microbiological diagnosis. What sample should be taken for VAP? What are the 2 samples that is usually taken for VAP or VAE? One is tracheal aspirate and another is bronchoalveolar lavage fluid. Bronchoalveolar lavage fluid and tracheal aspirate. So these are the 2 samples, respiratory sample in case of diagnosing VAP. Initial primary gram stain, number of bacteria and what type of culture should be done. In urine also, what type of culture is usually done? Semi-quantitative. That means if you take a plate, in normal inoculation, how we inoculate? This is the way A, B. This is the normal inoculation you have seen in your bacteriology class. Normal inoculation. This is usually not done for semi-quantitative inoculation. Semi-quantitative inoculation is some fixed amount of either tracheal aspirate, bowel fluid or whatever urine. You would start here, that loop should come here and then this is the method of semi-quantitative inoculation. Please draw either in CAUTI or in bowel fluid or VAP, semi-quantitative inoculation must be mentioned. Because without that, significant bacteriuria or we cannot differentiate between the colonization or ventilator-associated pneumonia. So if it is in tracheal aspirate, if it is the colony count is more than 10 to the power 5, it is, if it is less than that means it may be colonization. In bowel fluid, it is 10 to the power 4 CFU per ml. So this is the semi-quantitative inoculation in case of VAP also. The colony count matters whether it is a colonization or it is a true infection. So semi-quantitative inoculation is required. Most accepted chest X-ray or CT scan showing new infiltrate, consolidation or cavitation. Absence of underlying pulmonary or cardiac disease. Now empirical antimicrobial therapy, once the diagnosis of VAP is made clinically, empirical regimen should cover the gram-positive Staph aureus and also gram-negative Pseudomonas and other GNB. So what antibiotic we would prescribe? Covering both MRSA and Staph and Pseudomonas, Staph, Pseudomonas and other escape organism. Now what are the VAP or VAE prevention boundaries? Elevate the head end Supine has a more chance of VAP, so elevate the bed end for 30 to 45 degree. Oropharynx, even patient is not conscious, the cleaning of oropharynx with chlorhexidine. Sedation, vacation. Don't keep the patient under sedation whole 24 hours. Give some sedation, vacation, and assess daily or twice for extubation. Peptic ulcer disease prophylaxis and DVT prophylaxis should also be used. Now, surgical site infection. This question has come in, not in West Bengal, WBHs, in other examinations, surgical site infection question has come. Now, what is the new definition for surgical site infection? Surgical site infection, first that should be followed, that it means it should appear after 48 hours. But surgical site infection may not occur after 48 hours. From 48 hours to how long? How long you should consider it as surgical site infection by definition? 30 days of surgery. 30 days of surgery where there is no implant. No implant was used. If any cardiac implant, any stent, those are for implant. When it is implant is there, it is for 90 days. With implant. Surgery which has used implant, the duration is 90 days. Remember these 2 days of surgical site infection, 48 hours after surgery and up to 30 days even after discharge, it is considered as surgical site infection, and up to 90 days where some implant is used. So here the definition, surgical site within 30 days of surgery, within 90 days for some surgery, breast, cardiac or joint surgery where some implant is used, like hip replacement, knee replacements, implants are used, that is 90 days. Previously these 90 days were 1 year, that has been changed in last 1 or 2 years, that been made to 30 days and 90 days. Affects 1/3 of the patients. Type of etiology depend upon the surgical site procedure. Endogenous against patient own skin flora, exogenous operative personnel or instrument, inoculum load, GI surgery have a higher risk. Risk factor, age more than 60, malnutrition, diabetes, immune suppression, skin colonization at the time of surgery, duration of hospital stay, smoking, obesity. Now, how you can additionally protect from these? Any idea what are the another prevention methods from surgical site infection? Other is improper surgical scrub, inadequate skin antisepsis, prolonged operative time, inadequate antimicrobial prophylaxis. What inadequate antimicrobial? When this antibiotic prophylaxis is given? During surgery? Any idea whether it is before the day of surgery or after surgery antibiotic prophylaxis? It is either 1 hour before the surgery or intraoperative. So antimicrobial prophylaxis, now it is a dictum to use antimicrobial prophylaxis other than sterile surgery like eye. You need not give an antibiotic prophylaxis. But others where it is an infective surgery or any surgery of involving the viscous or direct organ, abdominal surgery, the adequate antimicrobial prophylaxis to be given. Inoculum surgery is increase in bowel surgery, bacterial virulence, ability to form the biofilm. Wound class. Class 1, clean wound, less chance of clean contaminated wound, hollow viscous, contaminated wound, dirty or infected wound, and class 4 is dirty and infected wound. So these are the 4 classes of wound. What are the 2 parts? SSI, maybe superficial SSI, develops at the level of superficial incision and within 30 days. Deep SSI develops at the level of deep incisional site like muscle or facial level. How you can detect the superficial SI? What type of discharge will be there? Patient either having local inflammation or some discharge. What is the type of discharge usually occur in SSI? It is not the pus, serosanguinous discharge occur in case of surgical site infection initially. Organ space SSI develop at the organ within 30 days. Systemic suture removal plus incision and drainage and systemic antibacterial therapy, these are the treatment of SSI. Preoperative measure. Preoperative bathing of the patient with plain soap or antimicrobial soap. For MRSA carrier, decolonization with bupropion ointment. Hair removal should not be done if not absolutely necessary. Should be removed by clipper. Must be provided a clean surgery. Standard antibiotic prophylaxis must be provided for all except clean surgery. 60 to 120 minutes before incision. As I have mentioned, the antibiotic prophylaxis is given 1 hour before the surgery. Other than absolutely clean surgery where chance of infection is not there, standard antimicrobial prophylaxis. Surgical hand disinfection, surgical site preparation, perioperative maintenance of oxygenation. Wound dressing to be done daily, removal of any discharge, OT disinfection. How the OT is disinfected nowadays? OT disinfection can also as a separate, when you get an environmental cleaning class or environmental surveillance you need, but how the OT is cleaned nowadays? Previously, formalin was used as a fumigation. Fumigation is not advocated nowadays. Don't write fumigation. You can write fumigation was used previously, but the formaldehyde part is carcinogenic to the healthcare workers, so formalin used fumigation is banned by all, WHO, ICMR, NCDC, all has banned fumigation. The most important is the surface cleaning, or you can at most use fogging. Fogging with other, like glutaraldehyde, one is composition of bacillocid, paracetic acid, or this can be used as a or for chlorine related compound. So surface cleaning is must, and common agent which are used for surface cleaning are bacillocid 2% or Varcon or paracetic acid. These are the commonly used disinfectant for cleaning the surface of the OT. Already I have covered during the prevention, just to cover urinary catheter, one is insertion bundle and one is maintenance bundle. Same is that catheter should be inserted when only necessary. Sterile items are used for insertion. Closed drainage system must be used. Catheter of appropriate size. You must use adult. Their size of Foley's catheter, size should be appropriate for the age. Daily catheter care must be given. Catheter is properly secured. Drainage bag must always be above the floor and below the bladder level. Closed drainage system used all the time. While collection from the urine bag, following steps: hand hygiene, change of gloves between the patient, separate jug. So whenever conservancy or housekeeping staff is changing the urine in the bladder bag, that should follow. They should also use gloves for prevention of infection. Daily assessment of readiness for removal. Central line, what are the insertion bundle, what are the maintenance bundle? Hand hygiene before and after the insertion of central line. Use maximum sterile item for PPE, site of insertion, subclavian preferred, avoid femoral. Femoral has a higher chance. Skin preparation by antiseptic like chlorhexidine. Skin preparation I have already mentioned several times in practical class. Either you use chlorhexidine with alcohol or use spirit, iodine spirit. Spirit, iodine spirit 3, or use chlorhexidine with ethyl alcohol or isopropyl alcohol, combination of chlorhexidine with isopropyl alcohol. So kiln must be properly dry before the use of, after the use of antiseptics. Use semi-permeable dressing. Document data at the time of insertion. Daily aseptic central line handling, hand hygiene must be performed. Half decontamination by alcohol. Daily documentation of local sign of infection, change of dressing with 2% chlorhexidine. Daily assessment for chance of removal. Central line maintenance bundle for mechanical ventilator. This is not for the central line, for the mechanical ventilator. Adherence to hand hygiene, elevate the head end 30 to 45 degree, daily oral care, peptic ulcer peptic ulcer prophylaxis should be assessed daily. Don't blindly give the PPI, that is the point. PPI decreases the gastric acid secretion and increases the chance of VAP. So you can use sucralfate instead. Deep vein thrombosis, that is low molecular weight heparin, should be given also. Daily assessment of removal. Now surveillance, I have already talked about hospital infection control committee. All the infection patient having some device should be monitored daily for the chance of infection, and before the monthly meeting of HICC, infection control nurse should calculate a data, how many VAP, how many CAUTI, how many CRBSI has developed in that ICU, and present to hospital infection committees. This is the duty of infection control nurse with the help of hospital infection control officer.